Hello, and welcome to Everyone Dies, the podcast where we talk about serious illness, dying, death, and bereavement. I'm Marianne Matzo, a nurse practitioner, and I use my experience from working as a nurse for 47 years to help answer your questions about what happens at the end of life.
And I'm Charlie Navarrete, an actor in New York City, and here to offer an every-person viewpoint to our podcast. We are both here because we believe that the more you know, the better prepared you are to make difficult decisions. Also, this podcast does not provide medical nor legal advice. Please listen to the complete disclosure at the end of the recording.
Welcome to this week's show. We're so glad to have you join Charlie and me for the next hour as we continue our series, Everything You Always Wanted to Know About Cancer, but Didn't Have Anyone to Ask, with a chat about prostate cancer. This podcast is a combination of education and entertainment delivered in 3 halves. Our main topic is in the second half, so you can fast forward to the chitter-chat-free zone if you'd like. In the first half, Charlie has our recipe of the week and a poem by Andrew Reynolds, a prostate cancer survivor. In the second half, I'm going to talk about prostate cancer risks, treatments, and other details about this disease. And in the third half, Charlie has a report about the challenges men's partners face after a prostate cancer diagnosis.
In our first half, Everyone Dies heads out to South Carolina this week as part of our summer road trip across the United States. South Carolina is home to the legendary Hellhole Swamp. Every year, it hosts a festival complete with a tobacco spitting contest and the 10K Hellhole Gator Trot, which is also known as Redneck Run. Unusual laws in South Carolina include: 1. If a man proposes marriage to a woman, by law, the marriage must take place. 2. It is illegal to keep a horse in the bathtub. And 3. When approaching an intersection in an automated vehicle, the driver must stop 100 feet from the intersection and fire a gun or rifle to warn horse traffic. You can ponder this over your next funeral lunch with our recipe of the week, Shout Hallelujah Potato Salad, which is sure to be a big hit. Hallelujah and bon appetite. Moving on, here's a poem from writer Andrew Reynolds titled, Fighting for Your Life is Boring. Fighting for your life is boring, unending sameness. 6:45 a.m., parking lot with the same 4 cars, truck, SUV, VW Bug, and red Audi in the same 4 spaces near the staff entrance. In the clinic, the lights flicker on, room by room, break room, hall, reception desk, then the front door opens. Walking the same path with my green bag and ID in hand, the same woman greets me with the same sad smile and buzzes me in. The mind numbs. The routine doesn't change. Sameness without end, comforting madness. Routine and protocol are the cure. Same beam at the same spot, small doses day after day to end the cancer. Endurance becomes the key. Just need to keep putting on the gown and lying on the couch. And each day, the cheerful chart nurse stops to tell me of another famous actor I remind her of. Please go to our webpage for this week's recipe for Shout Hallelujah Potato Salad and additional resources for this program. Everyone Dies is offered at no cost, but is not free to produce. Can we count on you to contribute? Your tax-deductible gift will go directly to supporting our nonprofit journalism so that we can remain accessible to everyone. You can also donate at www.everyonedies.org or at our site on Patreon under Everyone Dies. Marianne?
Thank you, Charlie. Sandy, I'm going to approach a second. Our topic this week is prostate cancer. The American Cancer Society's estimates for prostate cancer in the United States for 2025 are about 314,000 new cases of prostate cancer diagnosed, and about 36,000 deaths from prostate cancer. Prostate cancer is the second leading cause of cancer death in American men, behind lung cancer. About 1 in 44 men will die of prostate cancer. About 1 in 8 men will be diagnosed with prostate cancer during their lifetime. But each man's risk of prostate cancer can vary based on his age, race, ethnicity, and other factors. For example, prostate cancer is more likely to develop in older men. About 6 in 10 prostate cancers are diagnosed in men who are 65 and older, and it's rare in men under age 40. The average age of men when they are first diagnosed is about 67. Prostate cancer risk is also higher in African American and in Caribbean men of African ancestry than in men of other races. So, where is this prostate gland? The prostate gland is found only in males, and its job is to make some of the fluid that makes up semen. It is below the bladder and in front of the rectum, the last part of your intestine. The tube that carries urine and semen out of the body through the penis goes right through the center of the prostate. If you're a male and ever had a prostate exam, you know that this is done by the practitioner putting their index finger into the rectum, and when the finger is moved around, we can feel your prostate gland to see if it's large, bumpy, painful, and this is one way that you can screen for prostate cancer. A risk factor is anything that raises your chances of getting a disease, such as cancer. Now, you can listen to previous shows in our cancer series to learn more details about this. Related to prostate cancer, research has found some factors that affect prostate cancer risk. These are all non-modifiable risk factors, meaning you can't change them. The first one is older age. Prostate cancer is rare in men younger than 40, but the chances of having prostate cancer rises rapidly after age 50. About 6 in 10 prostate cancers are found in men older than age 65. Regarding race ethnicity, prostate cancer develops more in African American men and in Caribbean men of African ancestry than in men of other races. And when it does develop in these men, they tend to be younger. Prostate cancer occurs less often in Asian American, Hispanic, and Latino men than in non-Hispanic white men. The reasons for these racial and ethnic differences are not clear. And then family history. Prostate cancer seems to run in some families, which suggests that some cases there may be an inherited or genetic factor. Still, most prostate cancers occur in men without a family history of it. Having a father or brother with prostate cancer more than doubles a man's risk of developing the disease. The risk is higher for men who have a brother with the disease than those who have a father with it. The risk is much higher for men with several affected relatives, particularly if the relatives were young when the cancer was found. Then there are modifiable risk factors, those that you do have control over. And for prostate cancer, these are excess body weight, diets high in dairy products and calcium, and the best advice about diet and activity to possibly reduce the risk of prostate cancer, and actually any cancer, is to get to and stay at a healthy weight, be physically active, and follow a healthy eating pattern, which includes a variety of colorful fruits and vegetables, whole grains, and avoid or limit red meat and processed meats, sugar-sweetened beverages, and highly processed foods. Now, if you're wondering what your risk for getting cancer is and things that you could do to improve your health, there's a link in the show notes that takes you to a site that helps you determine your cancer risk. I would guess that you're aware that President Biden has been diagnosed with stage 4 prostate cancer, and there's been a lot of talk about why he wasn't being screened. There is a blood test to screen for prostate cancer called the PSA. which stands for prostate-specific antigen. Unfortunately, it's not always accurate. The PSA blood tests can sometimes have abnormal results even when a man does not have cancer. This is known as a false positive result, or have a normal result when the man does have cancer, known as a false negative result. False positive results can lead to some men to getting prostate biopsies, which have small risks of pain, infection, bleeding when they don't have cancer. These results can also lead to anxiety, even when a biopsy doesn't find cancer. On the other hand, false negative results can give a man some false sense of security, even though they might actually have prostate cancer. Another important issue is that not all prostate cancers are the same. Some might grow quickly, but others, most likely, would never cause a serious health issue. Even if screening detects prostate cancers, doctors sometimes can't tell if the cancer is truly dangerous and therefore needs to be treated. Finding and treating all prostate cancers early might seem to make sense, but some prostate cancers grow so slowly that they would never cause any problems during a man's lifetime. Because of screening, some men may be diagnosed with prostate cancer that we would never have known about otherwise if they hadn't taken the PSA test. It would never have led to their death or even caused any symptoms. Finding a disease like this that would never cause problems is known as overdiagnosis. A problem with overdiagnosis in prostate cancer is that many of these men might still be treated with surgery or radiation, either because the doctor can't be sure how quickly the cancer might grow and spread, or because the man is uncomfortable knowing he has cancer that isn't being treated. Treatment of cancer that would never have caused any problems is known as overtreatment. The major downside of this is that even if a treatment, surgery, or radiation wasn't needed, it can still cause urinary, bowel, and/or sexual side effects that can seriously affect a man's quality of life. Researchers are still studying if screening will lower the risk of death from prostate cancer. The results from 2 large studies have been conflicting, and they have not offered clear answers. So far, neither of these studies has shown that PSA screening helps lower the overall death rate from prostate cancer. Until more information is available, you and your healthcare provider should decide whether you should be screened for prostate cancer. There are many factors to take into account, including age, health, and family history. For example, you might feel it's more important to be screened if prostate cancer runs in your family. But the current recommendations for screening are this. At age 50, men are at an average risk of prostate cancer and are expected to live 10 more years. At age 45, for men at risk of developing prostate cancer, this includes African American men and men who have a first-degree relative, like a father or a brother, diagnosed with prostate cancer at an early age, younger than age 65. Age 40 for men at even a higher risk, those with more than one first-degree relative who had prostate cancer at any age. If no prostate cancer is found as a result of screening, the time between future screenings depends on the results of the PSA blood test. Men who choose to be tested to have a PSA of less than 2.5 may only need to be retested every 2 years. Screening should be done yearly for men whose PSA level is 2.5 or higher. If you're younger and develop prostate cancer, it may shorten your life if it's not caught early. Screening men who are much older or in poor health is less likely to be helpful because most prostate cancers are slow growing. And men who are older or have major health problems are often more likely to die from other causes before their prostate cancer grows enough to cause problems. Besides screening, we should be aware of the signs and symptoms of prostate cancer. So, signs and symptoms of early prostate cancer are that there usually are no symptoms when it's early. While not common, symptoms of early prostate cancer might include problems urinating, including a slow or weak urinary stream, or the need to urinate more often, especially at night. And if you see blood or urine, or if you see blood in the urine or the semen. Signs and symptoms of advanced prostate cancer means that, no, advanced prostate cancer means it has grown larger and is possibly spread to other areas. When prostate cancer is advanced, it can cause problems with urination and blood in the urine or semen, as well as other symptoms, including trouble getting an erection, erectile dysfunction, pain in the hips, back, spine, chest, ribs, or other areas from cancer that has spread to the bones, weakness or numbness in the legs or feet, or even loss of bladder or bowel control from cancer in the spine pressing on the spinal cord, weight loss, and feeling very tired. These symptoms can be caused by things other than cancer, so you need to contact your healthcare practitioner to help determine what's going on. There was some misunderstanding about President Biden's cancer grade that was reported as a Gleason score of 9. So let me tell you just a smidge about Gleason scores. Gleason score is not the stage of cancer, but rather if the prostate cancer is found on a biopsy, it would be assigned a grade. The grade of the cancer is based on how abnormal the cancer looks under the microscope. Higher grade cancers look more abnormal, and these tend to grow and spread quickly. So, cancers with a Gleason score of 6 or less may be called well-differentiated or low grade. These cancers tend to grow slowly and are unlikely to spread. In fact, some doctors have questioned whether they should even be called cancers. Cancers with a Gleason score of 7 may be called moderately differentiated or intermediate grade. Cancers with a Gleason score of 8 to 10 may be called poorly differentiated or high grade. Once all the testing is done, a plan for treatment will be discussed. Now, like I said, not all prostate cancers are the same. Some grow fast, others slow. Your healthcare practitioner may recommend active surveillance or observation. And these options are used when the cancer isn't causing any symptoms, it's small, and it's just in the prostate, is expected to grow slowly because it's a very low or low favorable intermediate risk group, and or it's based on results from a molecular test of the cancer cells. Active surveillance is often used to mean monitoring the cancer closely with a plan to treat it if tests show it's starting to grow more rapidly. Usually, this approach includes doctor visits with a prostate-specific antigen PSA blood test every 6 months and a digital rectal exam about once a year. Prostate biopsies and imaging tests can be done every 1 to 3 years as well. Exactly how often tests are done can be tailored to some extent based on each man's situation and preferences. And then there's observation, or what's called watchful waiting. It's sometimes used to describe a less intense type of follow-up that includes fewer tests and relies more on changes in a man's symptom to decide if treatment is needed. This is more likely to be a good option for men who are older or who have serious health problems. Some men might just not be comfortable knowing that they have cancer in their body, even if it's never likely to cause them any problems. This concern might lead some men to choose treatments such as surgery or radiation therapy, even if the treatment is unlikely to help them live longer, but is likely to cause side effects. If the cancer needs treatment, there are a range of chemotherapy, immunotherapy, radiation, surgery, hormone therapy, and targeted therapy. Our cancer series has podcasts on all of these topics, but hormone therapy is unique to breast cancer and prostate cancer. So that's the one I'm going to talk about today. Hormone therapy for prostate cancer is also called androgen deprivation therapy. The goal of the treatment is to reduce levels of male hormones called androgens in the body to stop them from fueling prostate cancer cell growth. Androgens help prostate cancer cells grow. The main androgens in the body are testosterone and dihydrotestosterone, DHT. Most androgens are made by the testicles, but the adrenal glands, the glands that sit above your kidneys, as well as the prostate cells themselves, can also make androgens. Lowering androgen levels or stopping them from getting into prostate cancer cells can often make prostate cancers shrink or grow more slowly for a time. But hormone therapy alone doesn't cure prostate cancer, and many cancers become resistant to hormone therapy over time. So, hormone therapy may be used along with radiation therapy as the first treatment for cancer that's still in or around the prostate, if the cancer is at high risk for coming back after treatment. Before radiation, they might use it to shrink the cancer to make treatment more effective. Or if the cancer remains or comes back after treatment with surgery or radiation therapy, especially if the cancer is spread or if it's not exactly clear where it is in the body. Or if the cancer has spread too far to be cured by surgery or radiation, or you can't have these treatments for some other reason. So, the possible side effects of this treatment are reduced or absent sexual desire, erectile dysfunction, impotence, shrinking of testicles and penis, hot flashes, which may get better or go away with time, breast tenderness and growth of breast tissue, gynecomastia, osteoporosis or blood thinning, osteoporosis or bone thinning, which can lead to broken bones, anemia, which are low red blood cell counts, decreased mental sharpness, loss of muscle mass, weight gain, fatigue, increased cholesterol swings, and depression or mood swings. Some research has suggested that the risk of high blood pressure, diabetes, stroke, heart attacks, and even death from heart disease is higher in men treated with hormone therapy, although not all studies have found this. So essentially what this therapy does is, if it's one term for it is called chemical castration. Back in the old days, before other ways of blocking the hormones were found, what they would do is they would remove the testicles from the man completely, and that would cut off the supply of the androgens going into the body. And that is how they used to manage it, but they don't do that anymore. Now, many side effects of hormone therapy can be prevented or treated. For example, hot flashes can often be helped by treatment with certain antidepressants or other drugs. Brief radiation treatment to the breast can help prevent their enlargement, but this is not effective once breast enlargement has already occurred. Several drugs can help prevent and treat osteoporosis. Depression can be treated with antidepressants or counseling. And exercise can help reduce many side effects, including fatigue, weight gain, loss of bone and muscle mass. Essentially, what these drugs do is put the man's body into like a menopause state. They're losing their testosterone, and so their other hormones are a little bit higher, and it is like menopause. And I've had men who I've treated for prostate cancer who would come in and they would just sort of sit and cry, and then they'd stop and they'd say, I just don't know what's wrong with me. I just cry all the time, and I have these symptoms. And I'd have to talk with them, remind them that their body is being deprived of the hormone that is essentially the male hormone that makes the muscles that manage the sex drive, that manage your response to to here's it, that manages the response to what do I want to say? That manages sexual response. And even though they know that that's what this drug is going to do to them, until it actually occurs, they have no idea what that feeling is. And I had one guy said, I understand my wife a lot better now. When she, would get her period, she would have this series of symptoms and would be more tearful and more depressed. And he said he was never really, he was never very understanding when that would occur, but he understands a lot better now. So what I've just told you is a lot of information, and you might need to listen to this more than once to get a full understanding about prostate cancer. But be sure you work with your healthcare practitioner to help make a plan and then follow it. Involve your family so that they can help and support you. And if you have any questions, please let me know. You can send us a message. You can send us nice thoughts at mail@everyonedies.org. That's MAIL at dies.org. So, Charlie, what questions can I answer for you? I saw your eyes get really big when I talked about the way they used to castrate men in the old days.
What? Yeah, that's well, yes, Mary, and that was interesting to hear about male castration. So, yeah, I got a couple of questions. Well, first, how often should men have a test for prostate cancer?
So it depends on your age and it depends on your family history. So uh, they would start screening at age 50 if you have an average risk of prostate cancer and are expected to live 10 or more years. They would start it at age 45 for men who have a high risk of developing prostate cancer, including African American men and those who have a first-degree relative like a father or brother. Diagnosed with prostate cancer at an early age, younger than age 65. And they would start at age 40 for men at even higher risk, those who have one or more first-degree relative or who had prostate cancer at any age. So it depends on those factors, what age they're going to start looking. The problem was back in the old days, like 10 or 20 years ago, they would do a prostate test on everybody, and then there would be these fluctuations, and it might be high, and they say, well, we don't really know what this means. You can have treatment, you cannot have treatment, and most people, if they're told that they have something that might indicate they have cancer, are going to want to have treatment. But what that led to was really a lot of overtreatment and leaving men who couldn't hold their bladder so that they would dribble urine all the time and might have to wear adult incontinence pads or things like that. Or, at age 40 become sexually impotent, not being able to have an erection or have intercourse. So there was problem with finding out the information on some, and for some of those people, it would never cause any problem. So that's why they came out with more specific screening guidelines.
So, I mean, I would imagine if there's like you said, there's a history of it. Obviously, you would get screened more often. But for men who don't have a family history of this, I mean, how often should someone be tested, for prostate cancer?
It's about every 2 years after the recommendations start. So if you have an average risk, they would start at age 50 and then check it every 2 years after that.
Okay, so clarify this for me, please. So prostate cancer, a colonoscopy, what does a colonoscopy do?
So that goes and looks for stomach or bowel cancers or rectal cancers. So it's a different organ entirely and a different type of cancer entirely. So it's like, what's the difference between a colonoscopy and a mammogram? Well, they're different places, different cancers that they're being screened for, different things that they're looking for. So there isn't one test or one blood test that can screen for all different types of cancers. So the screening for each type of cancer is different.
I mostly hear, prostate cancer associated with men, but do women also get prostate cancer?
Well, no, because women don't have a prostate.
Did not know that difference.
I was going to say it would be like men don't get uterine cancer because they don't have a uterus. We don't all have the same.
Of course,
organs.
Right. Yeah, vive la différence.
Yeah.
So you had mentioned hot flashes. I've never heard of hot flashes in men. Is this common?
Well, it's hot flashes related to the androgen therapy. So what they're doing is blocking the testosterone and the DHT, and so men have estrogen in very small amounts, but the androgens keep those in balance. But when the androgens are removed, there can be higher levels of the estrogens, and so you're going to have more of those menopausal or menstrual type of symptoms, and that includes hot flashes.
So this with hot flashes in men, is it specific to this, or are there other?
It's specific to the chemical castration, because if they weren't taking that drug, then they wouldn't be having those symptoms. Okay. So you remember in Fight Club where he meets Meatloaf and at the prostate cancer support group, and he has those really large breasts. So that's a symptom of the androgen. That's a symptom of the chemical castration.
Wow. Okay. All right. More information you have, the better. Thanks.
You're welcome.
For our third half, let's follow up on what Marianne said. Prostate cancer not only affects the man diagnosed with it, but also his partner. Howard Walensky reported on a 2024 study of partners of men diagnosed with prostate cancer to document the effect of the diagnosis on their lives. Based on 1,135 responses to an online survey of prostate cancer partners, the median age of respondents was 68, but their median age at the time of their partner's diagnosis was 61 years. Many respondents felt that their male partners needed support for mental health issues. 48% said their partner was not the same man as before treatment. They acknowledged having mental health problems themselves. Prostate cancer has a significant impact on the lives of partners, affecting their social life, and 20% said they felt lonely. 32% of partners say prostate cancer has had an effect on social and family life, and 19% said they have reduced participation in leisure and social activities. For all the strains that prostate cancer brings to couples, survey respondents said that communications channels have stayed open. and most partners felt that communication has remained good or improved since the prostate cancer diagnosis. 64% reported they can talk openly about his sexual abilities after treatment, but only 42% found it easy to express their own feelings about sex with partner. 72% of all patients and partners shared information about a cancer diagnosis with close family. However, they report feeling far less willing to share information about more taboo subjects, such as incontinence. 49% reported that their partners had continence issues, and 39% of respondents said that no one, apart from them, was aware of their partner's incontinence. 70% of the partners reported not receiving the information they needed about the impacts of treatment before it begins. Half of them reported needing to research sex after treatment to get the information that they needed. This lack of information about the impact of prostate cancer on sex life comes as a shock and made changes harder to adapt to. Although many partners think that prostate cancer has affected their relationship, most of them believe that the change has been for the better, bringing them together rather than driving them apart. A link to the study can be found in the show notes. And with that, please stay tuned for the continuing saga of Everyone Dies, and thank you for listening. This is Charlie Navarrete, and from actress Joan Hackett, whose epitaph reads, "Go away, I'm asleep."
And I'm Marianne Matzo, and we'll see you next week. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.